make the skin incision. Care is to be taken that you do not uh, 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 disturb the superficial branch of the radial nerve. So you can use a awl or a drill to make the entry hole, and you can just, once the entry is made, the hole may be circular, so you can make it oval by using a tip ronger. So once you've passed your uh, elastic nail, you can slightly bend it distally and curve it, contour it so that it takes the uh, smooth bend of the radial bow. And with slight left and rotational movements, you can pass the nail up to the fracture site. And once the fracture, नहीं बट इधर नहीं आया.
Sir, can I ask a question?
Yes, sir. Yes.
So the question is,
Yes.
all of us are doing nailing and plating.
Yes. Yes.
The problem comes when most of these injuries are high velocity injury. If it is, then the displacement of radius and ulna is much. You get a good reduction. Now the question starts from here. You see on table that distal radio ulnar joint is disturbed.
Okay.
In that case, how do you handle it? And you are done with the procedure.
Okay.
After 3 months, when the patient start doing rotational exercise, you find that DURJ is not functioning properly.
Yes.
How do you handle this situation later on? So
Okay.
these two questions.
So you're in pediatric age group or adult adult? Yes, I think I'll be happy if sir can pick up.
नाही ना, मी काय म्हणायचं तुम्हाला म्हणजे इन्फिरियर.
Sir, the set of questions are two. On table, you have got a good reduction. Nail is inside. You found that there is a distal radio ulnar joint injury. If you fix it, what are the points you take care of? On table, day one. And after 2 months or 3 months, you come to know there is a DURJ injury, distal radio ulnar joint injury. What precautions you are going to take, and how are you going to convince that patient that you need to fix this also, if at all it has to be done?
Actually, DRU injury along with the fracture both bone forearm, it is a most unstable type of injury. Generally, in a diphygeal fracture of the forearm, it does not occur unless there is a intraosseous membrane rupture. So, when you have a preoperatively also you can judge whether the inferior radioulnar joint is disturbed, not because of the length of the both radius and ulna, that you have a, then on table, if you do a anatomical reduction and still there is a subluxation after your nailing, then you give the cast in supination, so that what will happen whether it is reduced or not. If it is not reduced, then probably you have to go down and do a open reduction, something like that. But I have never done it in my life. And in that case, in supination, you just pass a ulnoradial KY for near about 3 weeks, remove it again, and then again you give a slap for 3 weeks. Probably everything heals around within 1 and
While
half month.
fixing this ulnoradial, do you press distal part of the ulna so as to get the good reduction, or you just pass it through?
No, you have to reduce it. See under image intensifier, and without changing the position of that arm, you have to pass the ulnoradial. Otherwise, what will happen if you do it like this and do a pass? It nothing because it is already dislocated. So it has to be reduced, and then you pass the ulnoradial wires, see the stability, and then probably everything heals that joint.
And now the second.
In spite of all these things, suppose there is a subluxation and dislocation even after 6 weeks, this can even happen in the plating also. So it becomes a very entirely a different set of injury. So it's a complex injury that you must keep in mind. that there may be a associated inferior radiolargine subluxation or dislocation that has to be looked when you do plating or nailing in fracture both bone or disc.
Okay. Uh, Without wasting any time, I'll go ahead. The difficult fractures of the distal tibia, whether to nail or a plate, it's a big question. Whether it is a pilon fracture or whether it is a just a distal tibial fractures. But nailing can be done because nailing is much preferred for the distal tibia extra-articular fractures, not for pilon fractures. Because pilon you need to have a lot of things. You need to wait till the soft tissue heals, and then you have to rotationally stable implant should be given and also associated with fibula, and the soft tissues are the most important to whether to decide. So most of the time, if you decide to do a plating, you should be very careful about soft tissue because you are passing through the already comminuted fragments. So reduction, maintenance of the reduction, rotationally stable fixation, polo screws and fibular fixation. So nailing on the distal third is not much of a soft tissue dissection. Its advantage, biggest advantage, disadvantage, not advantage is that you need not do any soft tissue dissection. You just have to pass the nail, but requires a proper nail. Sometimes you have to plan it so that sometimes the people get only 3 hole screws. You need to cut that nail and then use 2 holes of the distal, and then rest of the you can use either a small plate of the derotation or a polo screws. But for that, before that, you must do a CT scan. So rule out whether it is extra-articular or intra-articular extension, because most of the X-rays don't show any intra-articular extension. So you have to convert those extra-articular, intra-articular into extra-articular, and so that you can plan it. So the massive soft tissue problem is the crux and distal tibia, which is there, which will dictate you. So you have to wait and watch till the wrinkle sign, and whether the hemorrhagic blisters or it is a, just a serous discharge blisters, that depends upon the injury. You should be able to wait till the wrinkle sign, and you can sometimes you have to use sometimes a spanning external fixator if the massive injury is there. So the methods of reduction, that is very important. Anybody can nail it, but that maintenance and the reduction of the fracture, you need to learn this technique. Every conference we see here that they put a nail, they put a plate, but the reduction is the crux of the success. Those who really try to reduce those fractures are getting success. Putting a nail and a screw is not a big thing. Carpenter also puts a screw everywhere. So you have to be a gardener so that you take care of the soft tissue and then reduce it. So there are two methods. One is direct method and indirect method. But the reduction is in a, what is called a footprint concept. What is a footprint concept is you have to reduce the fracture without damaging the periosteum of the already precarious blood supply of the distal tibia. You know, the distal tibia is very superficial. There is a skin and the bone directly. And if there is injury plus the fracture has created a periosteal rupture, also the soft tissues around whatever the blood supply is there. So you, wherever you are trying to reduce these, you must use those sharp reduction forceps. You must have those sharp reduction forceps, which will give you a minimal damage to the soft tissues and keep it reduced till you last locking bolt is put. So don't, after removal, just don't remove it. Now this is a case, this is a compound case, injury, and if you see how distal it is, can I have the pointer? So distally, so anybody would opt for the plate because this is up to the here, it is fracture is here. So, but anybody would, but the soft tissues are not that good to have a plate. It was compound, so I decided to put a nail, which was very extremely difficult, but not impossible. So on the reduction, so we debrided, then this reduction clamp reduces this. You can use a temporary K wires and keep this clamp throughout the procedure. Don't remove it. Once you reduce it, don't remove it. So you have to plan in such a way. We have to use two clamps sometimes, one anterior posterior and one medial lateral also sometimes. So you have to use this clamp as a latch screw. So like a latch screw, you can put this clamp and keep it reduced that way. So that means how much is injured, this much only, not that damage to the stripping. Like a big bone holding forceps is not necessary to use it here. It's just a footprint of the bone, it is damaged, so that you will get a reduction. And then you throughout the nail, you pass it, then you can do it, lock it, and eventually the fracture is united with the. So as much as distal you can go, you can have a union of the fracture, because you are not disturb the soft tissues around in the distal fragment. So planning is very important. Is get the full length X-rays from the tibia, both ends of the tibia, correct length and diameter, because distally you have no choice, because once sometimes your screw can be in a fracture site, and that is a disaster, because that can break, because you can't lock it. So sometimes you have to cut the nail, and then the next day you can post it. So keep all the size and length available, because it's a magnification which you have. So the CT is very useful. Those who don't have a CT, it's okay. But those who have CT, they can have a magnification, and they can exactly with the software, you can collect, and they see the diameter of the nail also can be seen on the software. So the flat nail end can be used, because the nozzle, the nail, the tip of the nail, which we should not pierce inside the joint. So usually for distal tibial extra, as you go down, you must use this flat end tibia. So guide wire must be in the center. That's very important. That whenever there is a ring, everything, it should be as distal as possible in the. So sometimes you require a femoral distractor to keep it distracted, not necessarily external fixator, but also keep the locking plate ready, because if sometimes the nail passing a nail, or sometimes the secondary fracture can occur, so that you can keep the plate locking plate ready for those fractures. So if the fracture is extending inside the joint, then you must convert those intra-articular into extra-articular by using a latch screws, and then reduction clamps are very useful in doing this. So polar screws plays a very important role, especially in these metaphyseal fractures of proximal tibia and the distal tibia. So where it is used, how it works. So the concept is to avoid malalignment. And believe me, you must learn how to put a polar screw. Without that, you can't do a nailing in any distal metaphyseal fractures unless you know the technique. It is not a rocket science, something which is out of the world. You must learn with the first K wires, and then replace the K wires with the polar screws. So not necessarily every time you should use a screw and then change it. So that this is the really good method which is given by uh, okay. So this is the polar screw when there is a varus. Then you have to put polar screw more medially, and the distal screw more laterally. That way you can do it. This is the case. We put a polar screw on the lateral side, and then got excellent union. Whenever there is a valgus, there are the valgus. When you have this screw can be adjusted accordingly. So there is a valgus position. You can do a good position of the locking screws. And when there is a not possible to put, there is a central or a direct impact. Whether it is not possible, you can put two polar screws side by side nail. So they will not allow your nail to divert anywhere, valgus or varus. So that way, this is the patient of how distal fragment is crushed, and then you can use these two central polar screws, so that the nail remains center, both AP and lateral view, and then it gives excellent stability on the on X-rays. Same thing can be used for the segmental also. You can use again the polo screws, which gives you a very good stability on the lateral side. So converting intra-articular into extra-articular also is a art. You must for that you need to have a CT scan. This is a patient which here X-ray you don't see much of the intra-articular, but if you see there is a intra-articular extension here. See this, there is a posteriorly going. Everywhere there is a plafond fractures are there. So you must convert those into, before you take an entry point, you must convert those into it, and then you have excellent fixation of the fracture, the function. I have published this in 2015, the treatment of spiral and tibial fractures in the distal Journal of Orthopedic Surgery. So in conclusion, the distal third, if you go and oblique fractures, it's a soft tissue friendly. Basic, very important is the distal tibia, which is very precarious blood supply and the skin is very thin. So it is much more preferred if you are able to pass a nail, the nailing always preferred. Of course, it gives excellent stability with the addition of polo screws. It also gives a space. Also, they don't allow your valgus or a late valgus. There is the comminuted fragments. There is less chance. I'm not saying the 100%. Nothing is 100% in medicine, but less chance of going into a deformity once patient starts walking. Because unless you allow tibia to walk, that will not heal. That's very important. The polar screw must be used and to prevent any malreduction or a malposition can be avoided by using this polar screw. So take home message is you have to have a 3D CT to rule out any intra-articular extension. Plan the nailing. That's very important. Yes, everybody has a nail inside, but you need to plan it where you will be screw will be, obliquity of the screw, and whether the screw will, your locking bolt will come in your fracture site or not. All these are things. Then how will you reduce it? That's very important. And placement of the polo screw, you must learn the technique of polo screw. It is not difficult at all. Thank you very much for your kind attention.
Thank you, sir. There
Any
is a short
questions?
announcement. A car is parked in the parking area, number MH23 0009. The owner of the car is requested to please move this car in the parking lot. Governor's visit is there, so because of protocol purpose, we need to move this car. I repeat the number MH23 0009.
Sunil sir, मैं question ही पूछ रहा हूँ. Sunil sir, you have done both the things, plating as well as nailing. For distal tibia, extreme distal tibial nailing and plating. What is more these surgeons and patients friendly? Nail. But how difficult it's to execute, because if you do it in a 90-90 position or in any figure of 8 position or figure of 4 position, so it is how to judge that in some extreme distal tibial fracture, the rotational malalignment, one, we have to look for. And second is, if the nail is of not a improper proper size, at least we must pass 3 screws, including excluding polar screw in a distal. And if you use a polar screw, that may be. So 3 screws are possible. Suppose if you are not able to pass 3 screws, then what about the stability of the fixation?
You have to put additional plate. What I do is I plan it properly because the distal tibia you require, sometimes you have to cut the nail also. So we have hexa to cut it and then convert that. We have to check it on the computer. We have to make the exact length. And distal fragment, if it is more than 3.5 centimeters, then the distal tibial nail, the all Indian nails have got almost 4 centimeters from the tip. So between 2 to 4 centimeters to 3.5 centimeters, you can very well nail it. So if this is slight more distal, then you have to cut into the 2 screws if at all you are planning to nail it. But I keep the locking plate ready because that is the area which we have to be very careful. But reduction I use a wooden triangle because sometimes I have to nail the fibula also. On fracture table, I can't put a nail on the fibula. So I'm using a wooden triangle so that we can get a resolution, and also it gives a On table, you can reduction forceps can be used very easily.
The second question, when you do a locking, do you do a proximal locking first or a distal locking first?
Always distal locking first. Always distal locking, because that is a very important. I also don't give back slaps. Sometimes back slaps can create a fracture there in a distal fragment, which is very small. So if it is, I put a that, there is no need to put a black. You can just give a compression and then lock it. And I use a static locking. I don't use any dynamic locking.
Third question, whether you want to do a fibular fixation. If at all, if you want to do it, what are the indications of fibular fixation in a extreme distal tibial fracture? And what is your preference, whether nail or plate, and whether you do it for the first a fibular fixation and then go for nailing or vice versa?
If the fibula is 8 centimeters, then I always fix it. Preferably nail. If it is like a near 4 centimeters, I put a MIPO plate. And if not required, I would always prefer the nail for the fibula, because I will allow patient to walk as early as possible for the any tibia. You need to stabilize fibula as well. Fibula is also very important pillar of the stability. And if it is midway, which is very rare, the distal tibia fracture is there, and mid shaft of the fibula, which is very rare. So usually tibia fibula are in the same level. If you see the cases, most of the cases are nailed, or if it's not possible, you can put a plate. If the fibula is also comminuted, then better to prevent shortening, you plate first. And I always keep the fibula first, and I reduce the tibia with the clamp, keep it, nail it, fibula, and then fix the tibia later.
Again, last question. Even after, in spite of doing all these things, the valgus deformity is a much more common after nailing than the varus deformity. Our varus deformity is almost negligible. And if you find that there is a plafond of the tibia is in slightly valgus, will you revise it or will continue?
In valgus, I don't revise much. If it is more than less than 5 degree valgus, I don't revise it, because whatever you do, even if you after reduction, if it is giving into valgus, it is no issue at all. Varus is not acceptable, because the talus will not tolerate the varus force.
What is your take, Dr. Gawale sir, on a valgus of the ankle after nailing? Mike.
More than 5 degree, less than 5 degree. No, no, you have done the nail, you are on reduction, and on extend you saw there is a valgus. Whether you will revise it.
But by and large, at the ankle, valgus is not an acceptable deformity. Whereas they are not so painful as the valgus. Symptomatically, I'm talking. Don't mix up. Syndesmotic is a different injury. That has nothing to do with the virus. That doesn't alter the long axis. That is a different issue. But what is more symptomatic, varus or valgus? If you ask, valgus is more symptomatic. They are more painful.
So it is better if you see in the end, if there is a valgus deformity, then probably you can go again, remove the interlocking bolts, use a puller screw to correct the deformity and then redo it. So it is possible. So less than 5 degrees is acceptable, literature says. But if you are so accurate in doing all these things, you can revise on table so that the patient may not suffer with the painful ankle arthritis, though it is a subjective. I have not seen with the valgus also the painful arthritis. What is your suggestion?
Many of these valgus cases are because of shortening of fibula. If the fibula is shortened, then there is more likely to be valgus. In that case, you'll have to pull out the fibula to length, and then the valgus gets corrected. So if there is comminuted fibula, then it is better to put a plate or put jam the canal so that the fibula is brought to length and then nail the fibula.
Sunil sir, my question is that you have so many discussion of where to put a plate and where to put a nail. My simple question is that what is your criteria to put a plate, simple plate in the distal tibia fractures? When to put a double fixation that is plate plus nail for tibia?
No, that's what. Fibula I always uh,
For fibula, for tibia.
for tibia.
Yeah.
If there is a severe osteoporosis, and in spite of putting a nail, there is maybe a sometimes there is a secondary fracture we are not seeing, or the the hole comes at the fracture site. Though in spite of planning, if the hole comes in that planning, then we have to reduce your stress. So I just put a plate. The more the comminution on the medial side, I use a nail and a plate. Small.
Can a medial locking plate is suffix for that fractures?
No, locking plate is a big thing. We have to put a big incision and pass it
The
up high.
MIPO, my by MIPO.
Yeah, of course.
So
But
it is not
skill,
suffix instead of
it
going
can
doing
be.
both.
It can be. I'm not saying that plating is not to be done. My topic is that the nailing in distal, and in certain situations, you need to have a augmented. Once you are not sure about the stability of the distal tibia because of the osteoporosis, because of the lack of crushing, there is a bone crush, and there is also loss of reduction on table. So that time we have to augment that.
So my question to Gadegone sir, he has asked two questions there: when to do a proximal locking first and distal locking first. Gadegone sir, what is the advantage of doing a proximal locking first? You asked the question. No?
No,
Do
no,
you,
if you are doing it in a 90-degree, so what happen if you do a extension for a distal locking, there is a jig is pressing against the patella, and it's very difficult. So you have to make it a 90-degree, and therefore, suppose if there is a stable fixation and good reduction, if you do a proximal locking, remove the jig and do a distal locking on a plane surface. So
is, the,
that is one of the
is there
example.
chances of the nail going eccentric either medially or laterally by doing a distal locking in the second
No,
part?
that can be managed with the puller screw or puller pin manipulation. That is not the issue. But if you do it, but I nowadays do a supra patellar nailing
Nailing.
approach for a distal tibial fracture.
Thank you, sir.
Okay, thank you very much, sir.
So is
So,
there
and the question of yours, this Lingayat sir, when you use a small plate, if obliquity of the fracture and apex of the that particular superior part is on more on medial side, and it is not exactly touching to the distal cortex, there is an unstable construct, and in that case, apex stabilization small plate is required in a more and more oblique fracture.
What you learn in the past, sir, so tibia is the bone which require weight bearing micromotion to get a union.
So that is
Yeah, it is a basic principle any tibial fractures. It is a weight bearing micro motion at the fracture size which is needed. If you are fixing the distal tibia with a plate and the nail, is the micro motion possible at the distal
no, a micro motion will not be possible. It
muscle?
will be absolute stability
Stability?
because we
But
want the stable fixation.
tibia, the book says and the literature says the weight bearing is a stimulus for the union.
It
Micro
is,
motion is a stimulus
but
for the union.
how can you an oblique fracture will give you stability after weight bearing? Transverse fracture in a dynamic mode will give you stability after walking. Suppose if you weight bear on a oblique fracture and where the apex is little medial side, it will never give and it will be added instability and probably it will go for non. हाँ हाँ आया आया हो इथंच आहे आता त्या टेबलवर आहे उगीच करू काय ठीक आहे fracture is a mid-clavicular fracture. We must study the deforming forces because why they are important. It is for the reduction purpose. Sternocleidomastoid muscle pulls the medial fragment upward. Weight of the limb pulls the distal fragment downward. Trapezius and pectoralis major helps for overriding of the fracture. So this is a very typical deformity which you see in the clavicle fracture. What are the structure at risk? It is the most important thing, neurovascular bundle. So any type of a treatment if you do, whether you do a plating or nailing or a conservative treatment, you must respect and you must know the anatomy of the neurovascular bundle. And there is a only 10 mm a safe zone below the clavicle between the neurovascular bundle and clavicle. So keep it in mind that is only 10 mm to 12 mm. So mid clavicle fracture when to do a indication, all indications except in a compound fracture with a neurovascular bundle is an absolute indication for fixation. Rest, whatever it may be, they are relative indications for fracture clavicle fixation. So if you ask me, if this is the fracture is given to you, whether it is to be fixed or not, it depends on the contract between the surgeon and patient. That's all. So it's a greater than 2 centimeter displacement, 2 centimeter shortening, comminution and skin compromise, bone overlap. It's like a horrible picture, but you will see in our practice, this type of patients are also mostly asymptomatic after 3 months. Skin under geopardy, when there is a popping of a medial fragment underneath the skin, or maybe a small ulcer formation or a small punctured wound like kirit somaya on the cheek. So in a comminuted fracture, so these are all indications, and you can convince the patient to increase your revenue that these are the indication for your fracture clavicle fixation. Fixation indicated. So what to use? Whether you to use a minimal invasive treatment or anatomically contoured plates. Both methods give excellent result. It depends on how you prefer and do it. In conclusion with the meta-analysis, the present evidence from the meta-analysis, intramedullary nail was a more advantage method for the treatment of mid-shaft clavicle fracture, and this is a recently published paper in 2015. And now I publish this paper, a new concept in the treatment of clavicle fracture with a screw intramedullary nail, and this is published in Indian Journal of Orthopedic. Accommodate three-dimensional anatomy of the clavicle, typically inserted from medial side, based in fracture without comminution. Small incision at the fracture site may be needed. This is the screw intramedullary nail. Probably now everybody is aware of it. It comes under the various length sizes. But for a clavicle fracture, 2.5 mm is the best size for the intramedullary nail. So how I do it? Place the patient with a large bump underneath the scapula, allowing injured shoulder girdle to fall posteriorly. It's because it nullifies the forces of the muscles, and therefore displaced fragment they come nearer with this position, and also you see the prominence of the clavicle. A small skin incision 1 to 2 centimeter in length is made just lateral to the sternoclavicle joint anteriorly. Now why only 1 to 2 centimeter? It's because the medial 1 centimeter is the only part which is contains a soft bone. Rest of the clavicle bone is a cortical bone, and therefore if we want to do beyond that 1 or 1/2 centimeter, probably will not be able to do a entry point of the nail, and therefore this is most important is the identification of the sternoclavicular joint. Window near the sternoclavicle joint, as I said, it is a soft bone. Owl is past entry point is enlarged. And before you do this thing, with the K wire, you must ascertain that you are near the sternoclavicular joint. Because if you go higher up, you will injure the neurovascular bundle. If you go lower up, you will injure the lungs. Because lung, there is a first and second ribs are there. Therefore, it is a very crucial step. Reaming of the canal is most important medially. Unless you ream the canal and make it enlarge, you will not be able to pass the nail because it is a curved S-shaped bone and we are passing a molded though clavicle nail. Probably it may not match with the curvature of the clavicle. Pushing the shoulder upward to help to reduce the lateral fragment to medial fragment by manually or by a this is a towel clip manipulation. So just you put two towel clips percutaneously near the bone and then you try to manipulate it. See in the C-arm AP as well as in 30-degree capillate on caudal view. That is most important. Because in AP view it looks very good, but if you see caudal view, there is a translation of the fragment. And therefore, your reduction must be perfect in AP as well as 30 to 35 degree of both the caudal and the cephalic view. Negotiation of the nail through fracture side, it's a very crucial stage. Monitor every step because underneath there is a neurovascular bundle and lung. And therefore, it is. Hello. पाच जर थोडस ठीक आहे लिंक तुटून जाते ठीक आहे सो you have to see whether it is and it is the through and pro movement of your this bone holder or a screw holder you can touch as soon as you touch to the clavicle you will find there are some resistance just manipulate here and there loss of resistance will give you into the canal or into the chapter. If you are not able to reduce and negotiate the nail in the opposite cortex, you just give a very small incision of near about 1 centimeter and reduce it and pass the nail. म्हणजे नाकाला जीभ लावायची नाही की मला क्लोजच करायचा आहे यू स्लाइटली गिव्ह ए इन्सिजन अँड ओपन इट डज नॉट मॅटर व्हेरी मच and this is the you can see here how these are the stages of the nailing. Mostly it is a closed nailing 3-point fixation. Even you can do in a comminuted fracture it because that the screw fits into the metaphysis and the tip into the flat bone, and this is how it is. And if you are not able to such a displaced fragment it is impossible to reduce, and in that case it is better to give a small incision, negotiate the nail, and it's a mostly closed cosmetic surgery. In 8-year grossly displaced fractures freaked by adrenaline, and it is a stacking nail is done, and how it was a displaced, really it needs some stabilization, and you can see here how the fracture has healed. Segmental fracture. So I have innumerable example to share with you. Displaced fracture, nailing, and healing by a secondary intention, minimal invasive surgery. So take home message, in a surgically indicated clavicle cases, consistent achievement of union and low frequency of complication with screw intramedullary nail migration is prevented. It is a cost-effective, minimal invasive surgery. And why not plate? It is because it produces a very large scar, big scar. It is an ugly scar. A beautiful lady will not be able to wear the upper garment because of your scar and keloid formation. And most dreaded complication of plating, which is not described it is a supraclavicular dystocia. Dystocia. It's because it gives a very typical, a very bad sensation after formation of the neuroma, and therefore it is always how to do it. I will. This is 3 minute video. You can go through it like this. This is the position and surface marking. You can see here. These are all instruments. Very few instruments are required. Small forearm reamers are required and they are very easily available with Manman and anybody. This is the X-ray. We must assess the size of the canal. And if you are not able to negotiate in a narrow canal, don't do this surgery. Go for plating. It is a hole is created. You can see on the medial soft tissue, and then hole is dilated with the curved owl. And you can see here the curved owl. So, sir, at this stage, you forget about this reduction. Your aim is to create a hole inside the canal, medullary canal of the medial clavicle, and then you start doing a 2.5 and 3 reamer. And this is the most crucial stage where there is a maximum curvature is there, and therefore reaming is most important. And then you can use this travel clip, align, and then you can see this alignment here, and then pass the your reamer, and then you can pass the nail. This is the only crucial step, and just give a bend to the nail so that you can negotiate it properly. Then this is the negotiation of the nail, and once it is confirmed in AP and oblique and capillate picture, just go on doing a screwing of the nail, and it should go into the impact into the flat surface of the nail, and this is how it is. You can do it. This is the final sitting, and last sitting you can see here with the screw. Now it is going inside, and just do the screwing of the nail inside till it goes into the flat bone, and here it is in the um, medial corner. So small incision if it is open required if needed, and this is how it is. Fracture is open. Negotiation of the nail. We can use a clamp of a forearm reduction. Keep it reduced. Pass a nail, and then same procedure is given in small incision. You can see here how it goes inside by screwing. This is one of the example of a displaced fracture and the fixation by clavicle nerve. Minimal invasive surgery. Small incision. Okay, thank you very much for your attention. And anybody wants to ask this question, you can. Clavicle brace does not reduce the fracture, nor keep it reduced. Therefore, forget about this clavicle brace. Whatever the displacement it is there, after the spasm of the muscles goes down, then and then some improvement of the displacement occur. Clavicle brace never reduces a fracture and never brings the bone together.
Great.
Okay, sir?
My question is related with the implant removal.
Uh.
We found that at times while removing this implant, screw nail, the screw breaks from the nail and it's next to impossible to remove that nail.
नाही नाही ते तसं आजकाल नवीन नेल निघालेला इट इज अ सिंगल नेल. देर इज नो कॅप लाईक दिंग. पहिले वेल्डिंग घ्यायचं.
Previously, yes.
हा हा. आणि आता ते कसं आहे 2-3 सिरेशन बाहेर ठेवायच्या सो दॅट वी कॅन आयडेंटिफाय इट क्लिअरली. इन सपोज इन केस युअर स्क्रू इज नॉट पॉसिबल देन यू कॅन डिग इट अँड रिमूव्ह इट बाय बोन निबलर.
Sir, have you come across any complication like pneumothorax or hemothorax?
नाही, माझ्याकडे तर झालं नाही, परंतु इट इज डिस्क्राइब्ड इन द लिटरेचर आणि एनीबडी कॅन गेट इट. नो प्रॉब्लम. देर इज नथिंग स्पेशल अबाउट इट. इट डिपेंड्स ऑन द सर्जिकल टेक्निक. अब साला तुम लोग वहां घुसाएंगे लंग में तो क्या करेगा वो. क्या सर, बोलो बोलो.
Uh, uh,
We operated, my assistant professor operated, and he punctured the lung. There was a lot of pneumothorax, and patient was about to die. We have saved him. He took 3 months. He was admitted, and there is a dreaded complaint. One should be aware of this. Just saying everything is patient dies, he will screw you.
राजेंद्र, अरे शेवाड़े सर, ये गलती किसकी है? डॉक्टर की है, पेशेंट? हाँ हाँ हाँ,
Facts, this is very dangerous. I stop my unit. Don't do this procedure. It's abandoned.
वेरी गुड, वेरी गुड. हाँ हाँ हाँ.
I strongly support him. Don't take surgery on clavicle lightly. In a Canadian registry, in about 4 years' time, they had 16 cases of pneumothorax, and most of them had problems. So be very, very careful. I have overall my rate has gone down tremendously. I
ते
started off with
मुंबई वाले करत नाही.
खबर था यार, उनको डर लगता है.
हाँ, चार्जेस कारलेस हुआ, लड़की रही तो ज्यादा लेने का, और तो इंसिजन बैठा तो कम लेने का. चलो, और दिस इज ए वेरी कंट्रोवर्शियल सब्जेक्ट, राजेंद्र सर. दिस इज ए कंट्रोवर्शियल सब्जेक्ट, and as I said earlier, you try. हाँ हाँ हाँ. बरोबर, ठीक. पण ज्यांना ज्याला करता येईल त्यांनी करावं. हा.
I don't agree and don't use it.
चलो, okay. So this is the end, but it's a very good procedure. You just try it and learn it. Thank you very much.
Thank you, sir. Uh, Now we quickly move on to the next session, that is osteoarticular infections. I now invite Dr. Akshay Marwar, sir, to take over.
As we are lagging behind the schedule, we will quickly move on the next session, which is a very interesting session of osteoarticular infection, which is a nightmare for any orthopedic surgeon. So, our first talk is by Dr. Ayesha. I will just shortly introduce her. She is consultant, Dr. Ayesha Sunawala. She is a consultant division of infectious diseases and at PD Hinduja Hospital, Mumbai. She is visiting infectious disease specialist at Bridge Candy Hospital. She is head fellowship of infectious diseases by National Board of Examinations. She is textbook co-author of casebook of HIV medicine. She is co-author for National Treatment Guidelines for Antimicrobials used by ICMR and a member of the Scientific Steering Committee for Indian COVID-19 Guidelines Group. Dr. Aisha, please welcome. Will Sarang sir, please, can you please welcome Dr. Aisha? So Dr. Agashi will first have some introduction lecture. I will request the speakers of this session to be particular with the time, please. We are lagging behind the schedule. 10 minutes allotted to each speaker.
Modification in the schedule. Dr. Aisha, myself, and Dr. Aditya will take a combined session of 30 minutes. We promise that we'll finish in 30 minutes, but it would be a combined session. So to start off, okay. So this is a session. We are starting a session on osteoarticular infections. And to start off, I intend to make five bold statements. I call them commandments, but then some of you might feel that they are bold statements. First and foremost, there are several publications on open fractures, compound, infected non-unions, etc., stating that intramedullary nailing versus this type of implant useful for infected non-union, external fixator as a definitive treatment for open tibial fractures, Elizaro for infected non-union. Now all these state the truth, but only half truth. They don't tell you the complete truth, because the truth is the treatment of infected cases or prevention of infection is debridement first, followed by fixation. People just keep on talking about hardware. Beware of software. That is one. Number two, a very new definition or new phrase coined by British Orthopedic Association and British Association of Plastic and Reconstructive Surgeons in the book published 2 years ago on open fractures is don't consider wound debridement. They say there's nothing like wound debridement, because whatever you want to do is excise the wound after extending the wound. So wound debridement does not truly specify what you want to do. What you want to do is excise the wound, extend the wound, so that you are able to take out all the contaminated tissue or infected tissue. Three is, as I have discussed in the morning, the aim of treatment of a contaminated fracture, like an open fracture or an infected fracture, is convert that into a closed, uninfected cavity as early as possible. Have a good cover and have a very, very clean cavity. That is your aim. So your debridement or your wound excision has to be followed by appropriate cover. It may be closure, it may be secondary closure, it may be negative pressure to help you in healing anything, or plastic surgery management. Therefore, it is best to partner with plastic surgeons. Therefore, remember, don't judge the limb by x-rays. It is said that don't judge the book by its cover. So don't judge the limb by x-rays. On several WhatsApp groups, you would say that you will see x-rays and just a mention that it was a compound fracture or there's a small discharging sinus. No, you judge the by limb by its cover. As you can rightly, you can see that the cover is terrible, but the x-rays are good. So don't judge the limb by its cover, by X-rays. Lastly, team up with microbiologists and infectious disease specialists like Dr. Aisha, because earlier microbes were obedient. They would listen to you. Today they defy you. They defy you, they challenge you, because the resistance world over is increasing. Especially in our country, almost 20 to 30% cases have resistant bugs. And in fact, it is considered to be a hotspot for carbapenem resistant infections, which are terrible. Therefore, team up with these people and don't just blindly give antibiotics. So, with these five bold statements or commandments, may I request Dr. Aisha to discuss the world of microbes.
So, good evening, everyone. As we know, microbes can enter the musculoskeletal system from various sources. Very important source is hematogenous osteomyelitis, like we see in native cases, and you can have microbes entering from the oral cavity, the genitourinary tract, the GI, pulmonary focus, as well as skin and soft tissue infections. And these may be from seemingly minor trauma causing transient bacteremia or any instance of lowered immunity. The infections that happen due to hematogenous spread are most often due to Staphylococcus aureus, followed by strep and gram-negative organisms. We have gut as well as genitourinary organisms which can cause bone infections, and these most commonly are our gram-negative organisms, sometimes enterococcus as well as candida. What about open fractures? So we know that during an open fracture, the skin organisms, which are sort of permanent colonizing flora of the skin, get easy access into the wound. And in addition, you can also have contamination from foreign bodies and shrapnel that enter the wound. These could be soil organisms, they could be water organisms, depending on where this fracture has happened and the environment. For closed injuries and surgical site infections, it's mostly the colonizing flora of the skin that enters through breaches in the skin either during the time of surgery or after. And these are most commonly strep, staphylococcus, coagulase negative staph species. These are the only things that we should really think of there. Environmental or soil organisms, to go a little deeper into, most importantly, anaerobes, gram negative bacilli, sometimes non-tubercular mycobacteria, nocardia, and filamentous fungi also. And then you have water-related organisms. Again, important organisms like Pseudomonas, Aeromonas, NTM, other things. To give a quick sort of recap on surgical site infections with the concept of biofilm, I'm going to take you through this pictorial. So we know that within seconds of surgery, the surgical field is flooded with bacteria which are in planktonic form or floating or moving as single cells. Most of these bacteria are eliminated by the body's defense system as well as with antibiotics. The body forms a film over the implant resisting the bacterial infection. However, some of the bacteria adhere to the metal surface and to each other, and they compete with the body's cells to form a film. So it's almost like a race for surface. And under favorable conditions, that is for the bacteria, some of them succeed in attaching to the implant as well as each other, and they recruit more and more planktonic bacteria. In the presence of various favorable conditions like traumatized avascular tissues host defenses that are impaired, the bacteria secrete extracellular matrix and they get embedded. And this really is the sort of concept of the biofilm formation. We know that within the biofilm, there are various pathways for nutrients, but these cells exist in a state of lowered metabolic rate, decreased nutritional requirements, and hence even the systemic markers of inflammation and inflammatory markers actually reduce in these infections. The bacteria arrange themselves in three zones within the biofilm, and we understand that the ones that are in the most superficial zone are the ones that are most metabolically active, require the maximum nutrients. The ones deep below are the ones that are really in the dormant state, the persister state, and are least metabolically active. Biofilm doesn't just form on the surface of the implant, it also forms below the implant, along the holes at the fracture site, in the medullary canal, where white cells cannot penetrate. Antibiotics do not work because of this altered sense of metabolism inside. The patient really feels no pain, the inflammatory markers are normal, and importantly, the cultures may not grow. So you can see here that antibiotics are virtually useless for these organisms. However, these organisms, despite their lower sort of sense of metabolism, within the biofilm, they're very effective, very proactive, and they're actually communicating with each other all the time, exchanging tips for survival, for resistance, between each other as well as between members of other bacterial communities over there. And it certainly doesn't behave as a single cell colony anymore. It behaves as a very complex multicellular being. So these quorum sensing bacteria can sense when the environment is right, they can sense growth and decide on dispersion. And that's when they actually disperse out of the biofilm and enter the bloodstream, is when they can produce acute symptoms both locally and at distant sites. As I mentioned before, neither the white cells can penetrate, antibiotics don't work, and really signs and symptoms of infection may not be there. And this leads to a phenomena called frustrated phagocytosis. And this frustrated phagocytosis releases certain bacterial toxins, and with the biofilm, this can cause osteolysis. Intermittently, the films burst, as I mentioned earlier, and when they burst into the bloodstream, this is when the signs and symptoms occur. This is when the planktonic bacteria disperse into the bloodstream, causing acute, local, as well as distant infection. Osteolysis may eventually lead to implant failure with the burst biofilm. And in the case of the intramedullary nail, it may even occupy the entire medullary cavity. So if we were to recap biofilms, it's a safe abode for bacteria, it's a challenge for the surgeons, but most importantly, it's a disaster for the patient. Is that the only way that the bacteria can hide and escape from antibiotics? Well, not really. They can also form abscesses, sequestration, intracellular infections, as well as intracanalicular invasion. Unfortunately for us, most of the organisms that are capable of causing bone infections can also form very effective biofilms, and you can see them all listed over here. So my take home from this talk is that biofilms are really the primary mode of existence for the bacteria. They are the ones that contaminate the medical devices, facilitate the emergence of drug resistance, lead to chronic infections, and more often than not, they fool us. They're extremely elusive in their clinical presentation, the way that they grow gradually, cause deterioration, and negative cultures. Thank you.
Thank you, Dr. Aisha. Next.
So, so that preamble about biofilms and how infections are impacting us, the most important thing for us as surgeons is how do we diagnose? How do we know whether a patient is infected or not? Is there a criteria? Is there a definition? Is there any guideline? So this is what this talk is going to cover. So let's go through the scenario. 75-year-old female, IT fracture, diabetic recurrent UTI, being treated for it. Unfortunately, had this fracture had to be nailed, which was done, and surgery was uneventful. And the patient came back on day 15 with this. The standard question, all of us have faced this scenario. Doctor, ये क्या है? ये infection है, ये क्या है? And we have to give the answer with this, correct? So let's see how we can classify this patient. I mean, there's a traditional classification which has been established many, many years ago. Unfortunately, still unpublished. We've all used this classification. The best part about this classification is the same patient can fall into one of two criteria, one of two types. Type 1 is माझा patient, type 2 is दुसऱ्याचा patient. So if this is माझा patient, 100% infection नाही madam. There is no infection. This is either some vicryl or भरपूर fat है, sorry, that's fat necrosis. Apply a lot of betadine ointment, neomycin ointment, and take the best combination that is there. Linezolid, cefixime, metronidazole, with Linda, with Metro. Take all of this and you'll be absolutely fine. So this is माझा patient. If this is दूसऱ्याचा patient, and they've come to us for an opinion, then we become orthopedic surgeons. Sina tan ke we sit over there. So jokes apart, we all face these scenarios. We will keep facing them if we continue operating. So it's time we moved on from eminence-based or what I feel or what you feel or what we all feel as a collective body and move towards evidence-based orthopedics. So why do we need to define it? Obviously, we need to know guidelines, where to intervene, where not to intervene, and for documentation and research. So there are various bodies across the world, US, Europe, they've tried to establish their own diagnosis. And this study, interestingly, tried to assess this classification, these various classifications over 7,500 wounds. They applied these classifications and realized that there is no one classification that could define. If one classification would say this is not infected, the other would say this is infected. So there was no real consensus. So what they urged was there is a need for a single definitive criteria. We are still waiting for it. And in 2018, this expert group, like we have the periprosthetic joint expert group, this expert group of European surgeons, infectious disease specialists, microbiologists got together, came out with a consensus for fracture-related infections. Now, what they said is, whenever we have a suspicion for fracture based on the history or for infection based on history or examination, there are two confirmatory criteria on clinical examination. One is a fistula or a sinus or an exposed bone or an exposed implant. If you can see an implant exposed, it is infected. If there is purulent discharge or frank pus, it is infected. There is no confusion over there, and that most of us know. They've also given suggestive clinical criteria, like local symptoms of redness, maybe fever, radiological signs like osteolysis, loosening, periosteal reaction, which is very difficult to say. We classically known whether this is infective callus or good callus. We really don't know about that. New joint effusion, increasing trend of ESR-CRP. You know, ESR-CRP will always be raised post-op. But if it's a serial increase, then that's troublesome. Persistent wound discharge or new onset wound discharge. So all these are suggestive criteria. They've delineated these criteria, confirmatory and suggestive. But what they've said is this is not to provide guidelines for management, it's just to stimulate the orthopedic surgeons. But these are the red flags. We must now react and try and find whether there is infection, do something about it. And that doing, what they are saying is we should keep a low threshold for surgical debridement. Even if it is suggestive, we should have a very low threshold to debride that wound the minute we suspect that there is something wrong. So whether we have confirmatory criteria or suggestive, debride, send appropriate cultures, and based on this surgical debridement and cultures, they've given more criteria, confirmatory being 2 positive bacteria on cultures, like the periprosthetic joint consensus, or on histopathology, if we get smears like fungi can be seen or certain organisms can be seen, then it is a diagnosis. Suggestive, they've said, is 1, but again, in our setup, sending multiple samples becomes difficult. So even if one sample comes positive, consider it to be infection. But by now we've already debrided. That is how we've got this sample. So you add other criteria to it, and maybe this is a diagnosis. So what they've stressed on, and we would also like to stress on, is whenever you're suspecting something, debride, target, and give targeted antibiotics. Not just don't wait for confirmatory criteria. Even with suggestive, go ahead, because we've seen what these biofilms can do. Dr. Aisha has already explained that they form a surface, they form their colony, they cause osteolysis, antibiotics don't work, and by the time we wait for X-ray findings or frank pus, it may already be too late and the implant may already fail. So what we need is to do is attack early, excise that biofilm or whatever is formed, necrotic tissue, get that thing out, reduce the load of bacteria, and then whatever bacteria microscopic are left, there the antibiotics, targeted antibiotics can work, and that is how we can salvage the fixation. So that's the idea. Ultimately, the idea is to salvage fixation. Now, with this background that we need to debride, the question is when should we go in? So, if it's a based on that, there are three durations of infection. One is a very early infection within the first 2 weeks. Duration is not more than that. Second is subacute between 2 to 10 weeks, and then the patient comes very late with a lot of, a long duration of infection. Looking at various papers, various studies on people who got these patients at different stages, the longer the infection, going from 4 weeks to more than 10 weeks, if we debride early and try and retain the implant in the first 4 weeks, the success rate of salvaging that fixation and fracture is almost up to 100%. And that drops down to 50% if we wait for more than 2 months. So if we continue giving empirical antibiotics and then later try and salvage that fixation after 10 weeks, 1 out of 2 or even worse results will be there. We'll end up in an infected non-union with implant failure. So the goal is we've got a short window period, suspect it and act early. Otherwise, we will end up in a disaster more often than not. So that is what we implemented in this patient. This is our own case. We accepted that this could be early infection. Now, how you counsel the patient, say wound wash karna hai, but then do an actual debridement, or tell the patient, have that dialogue, that depends on the local setup. But the idea is to bite the bullet, investigate appropriately. Here we found abnormal signals at the nail entry point and the helical blade. Did a thorough debridement, excised all the necrotic tissue, can be clearly seen over here. Now, cultures from the tissue did not grow, but the urine had E. coli. That was probably the cause of the infection, which is what we treated with 6 weeks of piperacillin tazobactam. And we could salvage this fixation. This is at 6 months. Patient has no recurrence so far. Fracture is united, and we could salvage the implant in a patient with recurrent UTI, diabetic, old age. So we must be, definitions are for theory. Yes, we can use them as guidelines, but they are very difficult to define. We must be alert, proactive, operate before waiting for confirmatory criteria, because a lysis on an X-ray means we've already missed the bus. Debride, send culture-specific antibiotics. So to summarize in a nutshell, we keep hearing about fracture-related infection. So the mnemonic is FRI. We must face the facts, look at the signs and symptoms, react like surgeons. When we face our own infection, we become physicians and give antibiotics. Remember, we are orthopedic surgeons. Let's operate, and that is how we can end up with infection remission. Thank you.
Very talk better. Request again, Agashi sir.
माल लावलाय पण ते कनेक्ट नाही 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 तो लॅपटॉप कनेक्ट करायचा हे बंद करू का हा बंद करायचा नाही हिरवतोय ना हे बंद करा माईक करतो मी बंद लॅपटॉप तो लागेल हे करू बंद okay so now once you have established that there is infection then the next step is debridement and I just run through some slides some videos about how to debride. As we have been saying again and again, there are different ways to skin the cat. There are different ways of debridement. You and me are not going to think same every time, but I will just present how we have been doing it. Hello? Yeah. Thank you. So, is it only removal of pus and implant? Very often, people think that removal of pus is debridement. Now, friends, remember, pus is a product. It is just dead WBCs, bacteria with tissue debris and serum. It is a product of infection. and not a source of infection. In debridement, you have to address the source of infection. So as Dr. Aisha and Dr. Menon have already described, there is a biofilm. You must anticipate where is going to be the biofilm and you need to address that. Whether it is open fracture, whether it is infected non-union, or it is an osteomyelitis. So I quickly take you through osteomyelitis. We all know that biofilms can occur even in osteomyelitis, so chronic wounds. And there would be a large area of biofilm formation and pus. So if you just make a small window and let out the pus will come out, your markers will go down, but the source of infection will remain. And therefore, you need to address, make such a window that you are able to take out the entire suspected area of infection, like this. Now, this was a elderly patient, osteomyelitis for several years, discharging sinus for about 8 months. You can see there's a discharging sinus. The CT, X-ray, CT, MRI, clinical examination is very helpful for developing a plan. You need to plan well. So what is your plan? The assessment is like this. You have a, here you can see there is a cloaca, the tract is going inside and there are sequestra. So the planning will be excision of sinus and tract, excise the scar, excise the scar, add local antibiotics, take out all the biofilm, and most important, get good cover. Most important thing would be to mobilize the muscles and get good cover in this case. In femur, more often than not, you are able to mobilize the muscles, skin, and get a good cover. However, in tibia, very often you need a flap. So this would be our planning. The discussion with MRI consultants is extremely helpful, and then we decided that the lesion extends over about 9 centimeters, and we need to excise, make a window of approximately 9 centimeters with cloaca in the center. So this is the scar. You can see that the incision video. Yeah. So first step is marking the incision by excising the scars. If there are any sinuses, if there are any drain sites, everything needs to be excised. Very often drain site may not be in the line of incision. So remember, always take out your drain along the line of incision. In case it gets infected, you can excise everything. So excise this. Next video. So don't make a superficial incision. Make a bold incision. Go right into the deep fascia. These angles need to be cut sharply, otherwise they remain inside. And in one go right up to the deep fascia. Then the deep fascia is invariably adherent to the muscles. You need to mobilize the muscles later, as I suggested. The deep fascia also needs to be separated from the muscles, as you can see here. That's the sinus tract now. It is to be separated from everything. Preferable to keep skin also. In this case, the skin got dislodged. We could not keep it, but otherwise it's best to take out the entire skin with sinus tract and go into the bone. So here you can see the sinus tract. That's the tract. and that's the wall of the sinus, which is to be dissected from surrounding areas. And then you come to the pus, cloaca, which is full of granulation tissue, dirty granulation tissue. Video? Sorry. Video? So that is the time when you take cultures, deep cultures. Avoid taking cultures from sinus. There's a lot of contamination and they do not represent the real culture. So collect culture from this area, from the cloaca. Then around the cloaca, there are invariably adhesions. So release those adhesions, which will help you in making a window as well as closure. So here you can see the window is planned, marked, and use multiple drill holes to mark the window. With 5 and 10 millimeters, make a window, scrape well, but don't leave it at that. This window would be a source of fracture or stress riser. So what one has to do is use a burr or a nibbler or any instrument which will make the window elliptical with rounded ends. There should be no stress riser. Avoid making a rectangular window. Rectangular window often leads to a pathological fracture. Elliptical window is not likely to have a pathological fracture. Way back, almost 25 years ago, Dr. T.K.R. Raza, who was a past president of Indian Orthopedic Association, unfortunately passed away, he had got a best paper award in Wyrock for making window. And that is where he had stressed the window has to be elliptical. Since then, I have been following this and extremely useful technique. So use a burr. You need not, we have used Midas, but you need not use Midas. Just burr anything, any burr which costs 15,000-20,000 rupees can be used for this. So this is generally done after you have scraped the cavity, because otherwise all this bone dust would go in and your cultures would be contaminated. So from here, we have made a smooth window with rounded ends. Cultures to be taken from the cloaca, from scraping of the medullary cavity. Avoid putting additives like normal saline unless the culture is very small or you're going to send it next week. The common test we will be discussing in detail tomorrow. And the sinus tract, do not forget to send material for histopathology. Whatever is cultured is to be biopsied or sent for histopathology. Never forget that. Then, after collection of samples, you can give empirical antibiotics. In this case, we give piperazine tazobactam. And then you can see in femur, it is not very difficult to mobilize the muscles and skin and get a good cover as shown in this. That was the culture. This will be discussed tomorrow. That's the antibiotics that were given by Dr. Aisha. Generally in these long-standing cases, we like to put dissolvable or resorbable antibiotic, but generally not on day one. We wait for the culture sensitivity. That gives us another chance of re-exploring and finding out whether there are any remnants of infection. So, and the bleeding is also much less. Day one, there is generally a lot of bleeding, becomes very difficult to know, especially in femur where you can't use tourniquet to know whether there are any remaining foci of infection. So this is done after 4 days with vancomycin, and this is the chart we ask patients to keep. This is a pain chart, appetite and fever. That gives us an indication whether the patient is settling or not. This is, they are supposed to WhatsApp to our resident, and this is at 2 months, this is at 5 months, very, very comfortable patient. Now, Most important is anticipate where infective tissue would be located. Write down. Write down in soft tissues where it is likely to be located, in bones where it is likely to be located, and then try and address everything. Preoperative planning is vitally important in these cases. Thank you, friends. Aditya, ये दाखव. याची. हाँ. So, what happens? What happens after these windows? There's always a query that whether all such a big window would lead to pathological fracture. As we have been saying, rounded ends not likely to have a fracture. Clean cavity, clean bony cavity, the nature will try and prevent fracture by adding bone on all the sides. It's exactly for the door, there is a whatever it is called, that frame. The door frame is very thick. So the nature makes a frame so that there is no fracture. And over a period of time, as you can see here, at 3 months, 6 years, and 9 years, the window has practically closed. It's also API. It also, you can see, the first step is a good callus at this level. Here you can see, and in AP you can hardly see the window, and there's a thickened cortex here. So don't worry about making an adequate window. Adequate is important, but avoid stress writers. Thank you, friends. We generally don't. You can. Somehow I feel that the thermal necrosis will be more, because that time we would not like to put lot of saline, because if you do that, then the cultures are not likely to come positive. So initially we use drill so that there is less heat, and use osteotome and hammer. Correct. So that's why I said last few months or last few years, we have been generally avoiding to put local antibiotic cement on day one. Various reasons. As you rightly said, multi-drug resistant organisms are becoming very common. It is very difficult to anticipate. So number two is, day one there is invariably a lot of bleeding, and you are likely to miss foci of infection. We have missed pockets, first pockets on day one. So it is better that you tell all this to the patient, that I am going to do it in 2 phases. First is debridement. We'll wait for the culture, and then we will put antibiotics. Having said this, there are 2 things. Number one is the concentration of these antibiotics is very, very high locally. So it is possible that bacteria which are resistant to IV antibiotics would be susceptible when you put locally. Agreed. Number two, there are situations where cultures are negative. Then, of course, we need to use empirically. Generally, we put colistin and vancomycin. That's general. Yeah. Correct. Uh, Generally, we make it a habit to meet the radiologist beforehand for various reasons. One is they actually give you a 3-dimensional picture. See, it is very difficult for us to understand this. Number two, post-op we tell them what we have found, whether whatever they have told us has turned out to be right or wrong. So their expertise also has improved, and our anticipating problems has also improved. Especially in femur, you need to find out whether the vascular bundle is near your, especially when you are doing on the medial side. So it is better to sit with radiologists, discuss, and then take it further. Yes. Yes, as soon as culture is sample is collected, as soon as sample is collected, the anesthetist gives empirical antibiotics, and that is something Dr. Aisha and that is she's going to discuss tomorrow. I don't understand anything about antibiotics. When I started practicing, we used to use it extensively because very often the sinus would be, the track would be very difficult to make out on table. Then generally we used to inject it on previous day. It would stain all the tissues, but by about 12 to 14 hours, the all the other tissues will not become stained. Only the sinus tract would remain stained, and then it can be we could trace the lesion. Today, with MRI or MRI sinogram, so many times we do MRI sinogram, it is quite easy to anticipate where is the tract. We know exactly where is cloaca, exactly where is tract, and then it is possible to remove. Sorry? Con- Conray, Conray, Conray. Yeah, one minute. Let me complete that methylene blue. So once it is stained, it stains the granulation tissue also. So that is a drawback. Since it stains the granulation tissue, on table you find it very difficult to what to remove. So many times you see that the consistency of pus is different, the color of pus is different, the color of granulation tissue is different. All that goes away with methylene blue. And therefore, in last 10 or 12 years, we have not hardly ever used methylene blue. Correct, correct. It is quite common. Are we going to discuss it in the thing? We are going to discuss that. It's a very common thing, and we have published this in Journal of International Journal, Bone and Joint Infections, and it's quite common. And how to differentiate between
Last one question, please.
Yes.
Last one question.
are we going to cover that tomorrow? How often do you send for
Delegates can
microbacteria?
contact Akash sir afterwards for their queries.
Yes, yes. Cultures there will be a full talk on culture.
Thanks a lot, Akash sir. Thanks a lot. Thanks a lot, Dr. Aisha. Just interruption in the session. Dr. Karne sir is leaving for a meeting at Delhi. So I will like to request Dr. Gade sir organizing for this MOA Pathshala. Our AOA President Dr. Lingayat sir, AOA Secretary Dhule sir, immediate past President Dr. Devre sir, Dr. Shinde sir. We are felicitating our Secretary, MOA Secretary Dr. Karne sir, as he has to rush to Delhi for an IOA meeting. A nice memento presented by Aurangabad Orthopedic Association for Dr. Karne sir.
Well, I immensely thank association and the team led by Dr. my very dear friend Dr. Gade sir. Okay, and I feel really very sorry that I have to leave the meeting because of some commitments, important commitments. But thank you everybody for the excellent hospitality and excellent support. Thank you.
Thank you, sir. Coming back to the session, next lecture is Dr. Chandak sir. Role of negative pressure wound treatment in wound management. Sir, please 10 minutes.
Good evening, friends. After that, those excellent lectures about infection, how to debride, I'll be speaking on role of negative pressure wound therapy in wound management. This is possibly a last decade science. When such a compound fracture comes and initially wound cannot be covered completely after fixation, that is what my main worry. So patient comes, there is a wound, you try to close it by tension sutures and the wound gapes is a problem. You try to cover completely and there is fulminant infection, that is a problem. And, and there are minor skin gaps. So how do we manage that? And when such trauma patients come, which are difficult, challenging, and this patient already had pre-debridements procedure prior, and the wound still is bad, or when wounds are badly infected, negative pressure wound therapy definitely is a useful asset. This is how patient came to the hospital. To take up this example, how the negative pressure wound therapy helps. This was 30 years old male, had initial treatment in another orthopedic facility, and had bad infection, foul smelling, wound wash, lavage, etc. given, thorough dedicated debridement, negative pressure wound pressure therapy after first NPWT. So from the first picture, the immediate scenario changes. The wound effusions or the serous they are taken away. The bacteria down. The wound looks better from this position, and there is a positive healing response. As soon as you see a wound and it is worse, is your major worry. But when you see signs of healing in better vascularity, better granulation, you feel better. This is after second VAC therapy and after adequate wound debridement. So this was just before the flap. The bone segment was excised. This is everything improved. Cross leg flap, patient did very well. And whenever we do a cross leg flap, in the gap, we would put a cement spacer with adequate width so that we can reconstruct it. This was debridement. This is how membrane forms after the induced membrane formation. Irrigator, aspirator obtained bone graft. Look at those. They are packed into that. This is immediately after the procedure. The whole column forms, and this is the process of consolidation at 1 year. And since it takes longer to consolidate, you can protect with a subcutaneous lipoplate. And this is final result. What difference I found after Elizarov fragment and after the long segment graft with RIA is lesser amount of equinus because there is no distraction of synthesis. This is another case in a eraser of we had a flap transfer but gave way. The whole segment of middle tibia was exposed, and though the X-ray looks innocuous, but the dead segment of bone. Again, after debridement of this, the tissues around this, since it is for a long, long time, are almost like a avascular tissue. The healing potential is poor, the granulation is poor, and that improves with negative pressure wound therapy. 1 or 2 sittings, and then a cross leg flap, antibiotic space. Importance of vac in bad, contaminated, mud abraded, grease applied wounds. So this was difficult to manage, very difficult initially. This is almost radiological complete severed foot, but distal circulation was good. So the goals are you use IV antibiotics, stabilize, X-ray, debride, 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 and then this was debrided thoroughly, wash, lavage, etc. given, and then once the initial debridement is done, then something like a hydro debridement. So what does hydro debridement do in this situation is it takes away the fine layer of mud which is closely impregnated on the tissue. So that comes out, and then this is how it works. So there is a jet stream of water with vacuum. So it debrides and it takes away that impregnated layer of mud. Even this can run on a vessel and nerve. You are not crushing the tissues, it is just application like a paintbrush, and it debrides. Also look at the abrasions. So it may be a combination of cases. Look at the skin abrasion, which is actually very difficult to manage. So you can debride the wound skin abrasion. So the thin layer impregnated mud comes out. So you can debride that. You don't use it on a bone because otherwise the things become bad, the device becomes bad. So it can take away the most superficial layer. And at the end of one or two debridements, the patient is good enough to go for further procedures. So this is at the end wash, lavage done, fixed, and he also had incidentally the compartment, so that was done. And once you debride such a wound, lot of exudate is going to come. And that, if you take care of hemostasis, I would put it into a food frame. We call it fondly a samosa dressing. So anterior film, posterior film, sealed, and then low pressure, only 25 initially on day one, and medium pressure on that, and then a microvascular flap was given, and that patient healed, rested nicely on a foam so that there are no pressure sores on the heel because that area is denerved, and then foot shortening done for such a patient. And then 3 to 6 months down the line, he was quite fine. Another value of vacuum assisted closure. So if you take out a plate which is infected, so this was a patient, we took out the whole plate, etc., debrided completely, and then here the foam is applied as a vacuum assisted closure mode. So negative pressure wound therapy you can use for generating granulation wide open, or you can use for vacuum assisted closure. And for compound fractures where wound closure is a bit tricky, I like to use two mouthstretch sort of foam on both the angles of the corner wound. The wound is closed subcutaneously with Vicryl, and then low pressure negative pressure wound therapy. So this is how it goes. Compound fracture day one, debrided, fixed internally, then vac applied, foam applied, and on both sides of skin a thin film pasted so that skin soddening does not happen, and then vacuum assisted closure on that. This is how it completes. So once you apply foam, make a small nick, put a suction on that so that every blood etc which is going to come out immediately comes out, and then check the seal, and this is how the procedure is completed. Connect the tubing and then negative pressure wound therapy. This is interesting. So at 125, the maximum compression of the foam is going to happen. So beyond that, pressure use is possibly not much helpful unless the wound surface area is very large. Coming to the next use of wax, this was a side space injury. What not to do, we would learn from this case. Case received from out of station from Nagpur was managed by a primary replacement, and then that had a bad wound, as you would expect in such a case. That was a side strap injury, so that was debrided. So look at this wide wound, and here also stability provided by intramedullary L nail in a fashion and negative pressure wound therapy. So that healed completely without a necessity of flap. So VAC used as vacuum assisted closure, it brings tissues together, and at times you can avoid a flap. This is another compound fracture. Look at this bad dirty tissue. So all live tissue obtained, complete hemostasis, low pressure VAC, and then occlusive dressing check, apply sucking pad, and then the skin graft takes up well. Even on a skin graft, we would apply VAC so that it sticks very well, and then the patient is mobilized faster. This was another patient, had a plating procedure outside. This is how he presented around 2 to 3 months afterwards, and continued on the dressings and antibiotics. Again, debrided completely. Look at the whole compartment, anterior compartment muscles debrided, wash, lavage given. Then on the medial side, we applied a ECPO, that is extracutaneous plate application, so that patient is stabilized well, removed all plate. This is vacuum assisted closure mode. We could keep a thin foam, try to close it so that in the next vacuum dressing, You can close the wound or you can get a flap, whatever is convenient for that patient. This was managed with XT, good infection control, and the wound healed completely. So healing response, infection well under control, and patient healed well. This is bad infection. After initial management, this is, you can see the pus, bowel full pus coming out. He had this fixation pair, the enders nail were backing out, bowel pus. So that was it debrided. This is all complete necrotic wound. Again, vacuum assisted closure. And so inside there is a large foam, outside there is a thin strip of foam, and then try to get it closed so that a good drainage is obtained. This is another way of lacing in the back. This is how the wounds can be managed with back. This is another with a tubing and the dead bone excised in that case, only few slides. After removal of the first negative pressure wound dressing, this is how the whole debridement, the vascular membrane now form, and then we can do the further reconstruction. So this is final wound healing. In that bad case, bowels full of pus, good debridement, and look at the skin edges, the healing is really very good. VAC is definitely a good asset. If there are two wounds, we can combine them by a bridge of foam onto the skin, and the skin is pasted with a film so that there is no hardening. These are very useful applications of VAC, and VAC definitely helps in such a. So he had a split thickness graft, and that amount of secretions he had. So put a VAC, large grafted area is another good indication for VAC. So VAC is definitely very useful. You staple the foam inside the edges of wound so that it heals well, and all these wounds whack with a bed, so would be with an intermittent whack, so that some amount of antibiotic leaching is useful and then it drains. And early cover with negative pressure wound therapy also in compartment syndrome is also another use of whack which is very useful. It removes the whole messy situation, makes it comfortable for patient and for us to manage. Compound fracture is again common use where we can use if there is no much of hemorrhage. This is how we can use for compound fractures. Connecting sensor track 2-point combination can be done. VAC, friends, is really useful bone for use in various situations. Infection control, soft tissue management, wound closures. So you can use for various things with all the precautions you need to use for VAC. Thank you very much.
Very excellent presentation. Before the workshop starts, one question for Chandak sir.
Yeah.
Sir, one lecture is there. Yeah. So no, one last question. One last.
So first day after any debridement, there is a chance of hemorrhage, and one or two patients had hemorrhage in the ward. The canister rapidly fills. You have to be watchful for that. Sisters are informed that any fall in blood pressure, hemorrhage, pulse, ghabrat, you take care of it. The first day pressure I keep at 25 with the strength of the vacuum pressure machine at minimum, medium, and large vacuum pressure. So on the KCI machine, those calibrations are there. Next day, you increase to 50, 75. Suddenly, if you increase, then again some bleeding points may open up, and then increase the pressure to around 125, which is most optimum for a large wound and for infected wound. Ideal recommended is 72 hours ideal. In India, we convert ideal into what is convenient to us, what is convenient to pocket of patient. The cost to a patient of infected scenario is already drained of all his resources. They try getting more. It is really a challenge to manage their finances. But VAC is ultimately useful to them because from that infected scenario, daily dressing and messy situation, they now come to a situation where there is no wound, no smell. They're standing next day with all the reconstruction you do, and that is a game changer in their mind. Now they have started thinking that yes, we can be cured of infection, and that psychological boost is a tremendous advantage. Uh, Managing their finances is a big thing. Ideal 3 days, never more than 8 days, but we have used for 5 to 7 days in variable situations.
Thanks a lot, Chandak sir. Very nice presentation. One last lecture by Sangeet sir. Very important topic. When should not we should nail in a compound fracture? Dr. Sangeet sir. After that Sangeet sir lecture, we are going directly for the demonstration of PFN A2 by Yogeshwar Implants. उपराकोंडाला हृदय आहे, सर. वेळ.
So my talk is on internal fixation in open fractures, when and when not. In open tibial fractures, we have two major complications, infection and non-union. The infection rate reported in the literature range between 5 to 50% and the non-union between 7 to 60%. Intramedullary nails, primary rimmed intramedullary nail appears to be a reasonable option for management of Gustilo-Anderson type 1 and type 2 open fractures, whether it is in humerus, femur or tibia. So overall, there is a consensus about nailing them in femur and tibia. The problem is when you have 3A, B, or C. The question is that. So all uniformly, type 1, 2 have a uniform result. If you use appropriately in an indicated case, nailing. Regarding the plate fixation, when you use it in such situation, the complication osteomyelitis is about 19%, implant failure 12%, and they are greater than the intramedullary nails. And often you have to use in a MIPO technique fashion. Now, I'm going to discuss three cases. सगळ्या माझ्याच, दुसऱ्यांच्या नाही. Okay. So one had a problem related to the biology, second had a mechanical problem, and third is inadequate debridement. So this is a 34-year-old individual. He had a road traffic accident in 2009. It was a 3A open wound. That was his wound. I primarily nailed him with good fixation, stable fixation on day one. This is the wound as it appears after adequate debridement on the table. But everything was going right. But on 7th day, he developed fever, pain, fever, and redness. This is how the wound looks like. And subsequently, it changed in 2 weeks' time to this situation where you can see a scar, pus was coming out, the wound, entry site wound is also not healthy, and subsequently we considered debriding and VAC. Uh, this was at 4 weeks where you can see the necrosed comminuted bone all coming out, and we had to take out on the table everything which was loose. The nail was exposed. There was a pus discharge. Even that dead piece of bone was excised. Now, was that a mistake on day one on my part, or is it I have not estimated the soft tissues which were damaged at that time, or I should have used a different implant or have changed the course, or I should have been more aggressive in debridement. The, all in the bargain was to preserve those comminuted fragments. At 8 weeks, this was the situation after excising everything, repeated debridement. The wound was, after a whack, it was looking healthy, but he had 14 centimeter of bone loss at the end. I consulted a plastic surgeon. The plan was to remove the implant, clean the wound, X-fix, and a flap. So that is what was done, a free flap with the X-fix. At 3 months, the flap had completely accepted, no infection, ESR, CRP was normal, but how do we manage this 14 centimeter bone defect? So I decided to use a segment transport over the nail. I made a custom made nail with a provision of 3 holes to dock the segment. And this is how over a fixator, I first locked the nail,
use a fixator three ring concept where the central ring was used to transport that segment here. That is a corticotomy, that is a transporting segment. And the plan was once the transport is completed, we remove the fixator and lock at the provisional holes which were made on the nail. So everything was going all right. At 4.5 months, when the transport was complete and the docking was adequate, I decided to remove the fixator, but that segment migrated by about half a centimeter. I locked that segment, removed the fixator, and then allowed that to consolidate. So that is how the consolidation started, and it completed in 9 months' time. But at the docking side, there was a non-union, a small discharging sinus, probably from the screw. So I took out this screw and grafted that area with a cancellous bone. And at 1 year, this is how it looked like. So at 4 years, this is how it looked like, and this is what is function. He's back to the same work. This is his flap and the leg, equal limb lengths are equal. This is where we started and this is where we ended. That is after the implant removal. So all this took 4 years of his life. I am responsible for that. And he's back to his work after 4 years. He's doing everything. So what do we learn from this case? uh, is it my decision was wrong? Is it I did not address the biology, or I was over aggressive in nailing this situation? I could have managed by a fixator. So whenever you're deciding in principle, uh, open tibial shaft fractures, there are multiple factors which you must consider when you are making a choice of fixation. Whether that is that has adequate soft tissue coverage, how much is the gross contamination, is the mechanism of injury endosteal or periosteal, how is the circulation, what are the hemodynamics status at the local site, and overall risk, uh, his general condition, and the trauma scores. These are the points which one should consider whenever you are deciding whether to do a plating or a nailing or a fixator. Now, I hope this will be not covered in the lectures. Can I go ahead? Okay. The time of debridement. Open tibial shaft fracture should be debrided within 24 hours after the injury. Initially, it was a time limit which was thrusted on us. We should debride it within 6 hours, within 6 hours. But there is limited evidence to support the 6 hours rule. After 24 hours, the infection rate doubles. So hence, the general recommendation and the consensus is you should debride within 24 hours. 1 to 4 days, if you debride, the risk of infection remains relatively constant. Whether that means if you're debriding on day 1 or if you're debriding on day 4, the relative risk is almost same. Time of debridement, irrigation and excisional debridement, which Dr. Agashe also pointed, is a crucial part of treatment. At least one debridement must be performed. However, the timing of the first debridement is still a subject of debate, but it has to be within 6 to 8 hours or within 24 hours if uh, everybody has a different circumstances, different situation. So whenever possible, it has to be within 24 hours if you want to achieve that result. What is the role of antibiotics? Uh, Wilkins and others, there is a considerable reduction in the infection rate when the antibiotics were administered less than 3 hours after the injury compared to given more than 3 hours from the time of injury. And that infection rate varies from 4.7% to it becomes almost doubles. So whenever you get a patient, first thing is you give him appropriate antibiotics. Second case I am coming to, this is 60 years old, motor vehicular accident, a 3B compound fracture. That is his wound. He came within 3 hours, open wound with a connecting skin tag
anteromedially between the two wounds. That was his wound, how it looking like. And after debridement, that is how it looks like. And used a fixator after cleaning the wound, applied a whack at 48 hours. When we checked with the help of plastic surgeon, he said you can go ahead with the definitive fixation. You remove the fixator and go ahead with the plating, and that is what was executed here. The plastic surgeon who was with us, he covered the bone with a rotation flap from the available muscles, and then a split thickness graft, which was looking like this post op X-ray. That is his skin, how it looks like at 5 months. He started weight bearing. I hope everything is well inside, but he developed a varus deformity, and on X-ray the plate had bent. So this was a stage at 6 months. He had a good knee range, good ankle movement, no pain. The only thing is this was not, the construct was weaker. So I improved the construct by adding more number of screws in the segment, reduced the working length and grafted it. At 3 months, this is was follow up. He was doing well. I don't know how दूसऱ्याचा झाला का. I have lost his follow up because of COVID. So here, probably the soft tissue was all right, unlike the first case. The mechanical problem, which was addressed like this. I quickly moved to the third case. This was a segmental tibia. That was his wound. Probably some can grade it as 3As. I can grade it as 2. And I nailed him. There is a varus here, probably instability on the medial side. And on fourth or fifth day, this is what was his wound. Probably my mistake. I didn't debride it adequately. But whenever you have a bargain of doing a good fixation and debridement, probably you tend to err more on the debridement rather than the fixation. So after a good debridement, this was covered. This is what his wound looks like, but his distal fracture was healing, the proximal fracture was not healing. The screw has loosened, the gap has increased. So I